Yeah, hi everyone. Welcome to my YouTube channel. Our next topic for today will be on hypertension management. I know it's a disease quite common not only in Africa but also globally. So I've choose this topic on that to make sure that my customer or client listener are aware of what it is. And here we go. Hypertension management in 2025, latest guidelines and clinical approach for optimal care. Why this matters in 2025? That's the big question. Hypertension remains a leading cause of cardiovascular disease, what we call CVD, stroke, and kidney failure, yet control rate lacks. With new evidence and guidelines, here is a quick actionable update for clinicians. So essentially this video is not just for nurses or pharmacists, but also medical doctors are supposed to have an idea what it is if they have that time. It's a summarized video. It wouldn't take you much of your time to listen to it. Number one, updated diagnostic criteria prepared by JNC 8 and ACC slash AHA 2025 consensus. We have normal blood pressure, which is supposed to be less than 120/80 millimeters of mercury. We do have elevated blood pressure, which doesn't mean that you have to take medication right away. And that one goes from 120 to 129 for the systolic blood pressure and less than 80 millimeters of mercury for diastolic blood pressure. We now have stage 1 hypertension, which goes from 130 to 139 for systolic blood pressure, and then 80 to 89 millimeters of mercury for diastolic blood pressure. And then stage 2, which is greater than 140 / greater than 90 all millimeters of mercury. So that's what you have to do. So therapy can start at this stage, not before. Confirmed with, we start with office blood pressure, which should be greater than 2 readings on greater than 2 visits. So meaning that you need to make 2 readings in more than 2 visits, not that you make 1 visit and you start taking medication right away. Then we have home/ambulatory blood pressure to roll out white coat /mask hypertension. So let me explain a little bit further what this is meant. So there are some people that when they go to the walk-in clinic and they find this doctor dressed in the white coat, they go into kind of panic and the blood pressure starts spiking, and that's what we call white coat hypertension or mask hypertension. Mask hypertension also can be while you are sleeping. You don't know that in the night your blood pressure spikes. So those are some of the things that we take into consideration before deciding if you have to go on therapy by taking medication or not. The next point, 2025 blood pressure targets individualized, meaning that if your brother or your uncle, sister, auntie has a blood pressure, we don't just generalize things that way. We need to first of all look at individual as a patient. So we start with your age. If you are less than 65 years old and your BP is less than 130/80 millimeters of mercury, that's good. Greater than 65 years old and blood pressure is less than 140/90 millimeters of mercury, relaxed if free. Then CKD, or DM or CAD, that's coronary arterial disease or kidney disorder, that's chronic kidney disorder. That's what those abbreviation stands for. The CKD, DM for diabetes mellitus, and CAD for coronary arterial disease. Then number 3, we have lifestyle first, non-negotiable in 2025. We have the DASH diet, which I've been saying time and again. That consists of fruits, veggies or vegetable, low-fat dairy products. And then we have your sodium. It has to be controlled because they create what we call hardening of the arteries. And that's why the blood pressure easily spikes. So your daily consumption of sodium should be 1,500 milligrams per day. We have exercise that helps to relax the muscles and also expand them and improve on blood circulation. So I would say 150 plus minutes per week. That should be moderate. The next one is alcohol for men. We say less than or equal to 2 drinks. And for women, less than or equal to 1 drink a day. Then we do have weight loss. So the target should be BMI less than 25. BMI stands for body mass index. That's the meaning. So watch out for your BMI time and again. The 4th point is pharmacologic management. 2025 first line picks. So we have classified drugs in various families and also in priorities, which one comes first. So in this case, the thiazides, and among the thiazides, I would say the clothalidone should be your best bet in this case. The clothalidone should be given, and also make sure that you monitor the patient kidney. Then we have the calcium channel blockers, that's CCBs. And in that family, number 1 is amlodipine. So that one should be your next. Then we have the angiotensin enzymes inhibitor or ERBs, angiotensin receptors blocker. So either one or the other should be okay. And in that family, we have the PROS. The PROS belongs to the ACE inhibitors, whereas the sartans belongs to the ARBs. Then we've got now special populations. For example, the black people. The black people, I would suggest we put them on the thiazide, but it's not that well guaranteed. So most of the time, I go with calcium channel blocker as preference. Then we have now the CKD/diabetes. So if you are having kidney failure and diabetes, then in that case, you either go for the ACE inhibitors or ARBs to protect your kidney, what we say here, renal protection. We now have post-MI. Yes, so this case has to do with heart failure. So for MI/HF, so we still use ACE inhibitor, beta blocker, and plus or less the MROAs. So those are a class of drugs that we do recommend in this case. And lastly, for pregnancy, we have 3 medications here. We have the methyl dopa, we have labetalol, and nifedipine. So those are the 3 drugs that should be used for pregnancy. I repeat again one more time. We have the methyl dopa, we have labetalol, and nifedipine. Then we have now another case we call resistance hypertension. So for resistant hypertension, 3 drugs can be used in that case. Still uncontrolled, you need to do something. So there's what we call here add-on. So add-on is in the case where the first two drugs are not working and now the third one can follow. And you need to check for poor adherence. That is, poor adherence is when the patient keeps to the rules put in place by the prescriber. We also go for secondary causes of this resistant hypertension. What is giving this patient this high blood pressure? So secondary causes, and then renal arterial stenosis. That one has also to be checked. Primary aldosteronism, that's another one that has to be checked as well. Pheochromocytomia or cytoma is another aspect to look into. And in that case, if it turns out positive, then we have to add spironolactone or any loop diuretic in that case, and make sure that you check for estimated glomerular filtration rate, EFR. It should be less than 30. Pro tips for 2025: recheck BP techniques, assess adherence, peer burden, cost barrier, reinforce lifestyle before escalating meds. Who should see this? Obviously, I will say everyone. This video is meant for everybody, as well as new graduates, or call them newly registered in medical school. They need to also have an idea what it is. So far, so good. My name is Dr. WAN, and I've come to the end of this video. Thank you so much for listening, and have a wonderful evening. Bye.